Welcome to the Gifford Provider Podcast, the podcast of Gifford Healthcare located in central Vermont. My name is Scott Fleischman, and Gifford is a nonprofit critical access hospital and federally qualified health center with a total of 9 locations. The medical center in Randolph is home to a 24-hour emergency department, inpatient and rehabilitation units, a renowned birthing center, an accredited cancer program, advanced diagnostic imaging, surgery, and much more. Go to giffordhealthcare.org to find the services we provide, the latest news, blogs, and information. Our guest this month is General Surgeon Dr. Aleksandr Sokolovsky. Dr. Sokolovsky joined Gifford earlier this summer along with his wife, Dr. Dawn Holman, also a general surgeon. Dr. Sokolovsky is going to be discussing colorectal cancer, the new guidelines for screening, the screening process, and how to reduce your risk for colorectal cancer. Now, before we get into our conversation, if you're watching us on YouTube, don't forget to click the subscribe button, like this video, tap the notification bell. That way you'll always know when we have new content for you to watch. And on our YouTube page, we have other podcasts, important information from our medical team, testimonials from our patients, as well as our employees. And you can now listen to the Gifford Provider Podcast in your car or while just going for a walk. We are on Spotify, Google, and Apple Podcasts. Just do a search for the Gifford Provider Podcast. Follow the podcast and share it with your friends. Dr. Sokolovsky, thanks again for joining us this month. A very, very important topic. Of the cancers that affect both men and women, colorectal cancer is the second leading cancer killer in the U.S. And obviously with these new guidelines out, this is something that's very important people need to be aware of.
Absolutely. I think the colorectal cancer is more dangerous in a way that it is very difficult to detect without actually visualizing it firsthand. So in other words, there are very few symptoms that could warn a person that they may be developing this type of cancer since it lives inside the body. And so the prevention and screening becomes extremely important, starting at a fairly young age, now down to 45 years of age.
And we'll talk about why that changed to 45 in just a bit. But first, before we really get into this, let's dive into your background, your history a little bit. I know I have one of the best jobs here at Gifford because any of the new providers come through my office, and I get to do a kind of a pre-screening interview and find out people's history and how they ended up at Gifford. And your story is so unique. Tell us why you decided to get into general surgery, your background. I mean, you've been all over. To say you've been all over the world is an understatement because obviously growing up in Russia. So tell us a little bit about that.
Well, I immigrated to the United States when I was fairly young, at 18 years of age, and right after high school. And so all my education post-high school was done here in the States. I went to college in St. Louis, Missouri, and medical school in Chicago, and did my residency back in St. Louis, and have had medical practices, surgical practices since then in 4 different areas of the country. I've been doing this for over 20 years. I've always wanted to be a surgeon once I got into medicine. I love interacting with people at that level, having patients, having been able to fix things that need to be fixed and making patients feel better. There is a little bit of immediate gratification to surgery where you get to actually see the results fairly quickly. Some of it is more of a lifelong process, like colorectal cancer screening, and I get to know my patients for a longer period of time with that. I also want to mention that I'm not a gastroenterologist. The gastroenterology is only a fairly small part of my practice, but it is an important part of my practice, and colorectal screening is, I think, one of the most important parts because we get to prevent something that could potentially be fatal to a patient in a fairly short period of time if it is missed.
And we mentioned your wife you came here with your wife, Dr. Dawn Holman, also a general surgeon who specializes in breast cancer and surgery. And you were a resident, right, where she was in St. Louis, right? And that's no, it wasn't St. Louis, it was
Chicago.
Chicago, that's right, and that's where the two of you met.
Right. I was a medical student in Chicago. She was a resident in Chicago, and so after my medical school there, I moved back to St. Louis for my residency, and then she finished her residency and became an attending surgeon at my hospital. So we were training together at different levels for I would say 8 years.
Wow.
Yeah.
And you've been here at Gifford now a few months, right?
Since April.
Since April. So what's the experience been like here so far?
It's a great community. We love the town. The hospital is wonderful. The one thing I think that stands out about this particular hospital and this community is that it seems that at every level, from nursing to physicians to administration, the number one priority is patient care. So everything's about the patient. Everything is about making sure that the patient gets taken care of at all levels. There's essentially no politics. There's no very minimal disagreement. Basically, everything is geared toward patient care, and this is very refreshing. It's very difficult to find nowadays with a more corporate approach to medicine in most other places where the patient care is still number one priority.
And if you're looking for more information, WCAX, the CBS affiliate here in Vermont, did a great story on Dr. Sokolovsky and Dr. Holman, so you can check that out. You can see more also on our social media pages, our Facebook page. Just look for Gifford Healthcare, and on our Instagram page as well, Gifford Healthcare or Gifford Medical Center. And just a great story, and we're just so happy and lucky to have the two of you here. You're so versatile. General surgery is something that we've lacked here at Gifford for a while now, and I've been able to sit in on a couple of procedures, and it's just been really, really cool. And one of the procedures I got to sit in on was a colonoscopy. I got to see that procedure being done. And again, it's when you're talking about screening, colorectal cancer it's the number one way to prevent it. It's screening. First, before we go into that, what can you tell us what colorectal cancer is? Why do we see it? What are maybe some of the risk factors?
Well, colorectal cancer is very similar to other types of cancer that we may have in our body. As I mentioned earlier, the difficult part about colorectal cancer is it's difficult to catch early unless you look for it proactively. Unfortunately, the symptoms of the disease don't occur until it is well developed, and it frequently is at a later stage where it's much more difficult to cure. The cancer develops from a benign process, from a benign polyp inside the colon. This is not unlike, if you can imagine having a small mole on your skin that could be there for many, 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 many years and can be benign for many years. And then all of a sudden it starts changing after exposure to sunlight, etc., and can become cancerous on your skin. It's a very similar process inside the colon. Unfortunately, inside the colon, we can't see it readily. So once the polyp, a benign polyp that could be present for a few years, becomes malignant and grows larger, it is very difficult to detect unless you go looking. And so once the cancer grows large enough, it can cause some bleeding, it can cause obstruction, it can cause perforation of the colon, and obviously it can spread to other organs, and that becomes eventually fatal if it's not treated. Again, prevention and detection and diagnosis is number one priority.
9 out of every 10 people whose colorectal cancers are found early and treated appropriately are still alive 5 years later. So it's so very important. It's just one of those, like you said, it's something that you have to stay on top of early.
Right. Yeah. If you think about, instead of thinking about treating cancer, if you think about preventing cancer, in other words, if we go in and do a colonoscopy in somebody who's 50 years of age, or now 45 years of age, which is recommended, and we remove a few, 1, 2, or 3 or more benign non-cancerous polyps, which could have slowly grown into cancer had we not removed them earlier, we're thereby preventing the cancer from developing in the first place. And then at the regular intervals, depending on what type of polyps they are, 5 years or 10 years, et cetera, we go back and remove more and more benign polyps. Those are the ones who would have become cancer if we didn't remove them. So we are practically preventing the cancer from happening in the first place, and that is the number one goal. And that is extremely effective, very logical, and makes perfect sense to everybody. Unfortunately, in our society, the colonoscopy part of the procedure is stigmatized somewhat, and we need to destigmatize it and try to fight against that, because the good that it does is so far outweighs the inconvenience or discomfort that associated with sometimes with this procedure, which is minimal nowadays because everybody goes to sleep for it. There's no pain involved, etc.
It's my hope that here at Sharon Health Center, we will be able to help you get any level of injury under better control. And if we can't take care of you here, we will definitely get you to the people who can take care of you.
Do you think that's part of it, the stigma, the reason just people are just freaked out when they think about the procedure, and that's really just gets in their head and they just...
I think so. I think stigma is a big part of it. I think when I talk to my patients, I sometimes mention that there's no pain, there's no discomfort during the procedure. It's no different than, actually, it's better than going to a dentist, because at a dentist office you are going to feel that shot that's going to hurt, or something's going to hurt at a dentist office. Very rarely is it completely pain-free. Whereas here with the colonoscopy, yes, there's a little bit of discomfort the day before where you have to drink the laxative, and go to the bathroom. And, obviously this is not pleasant. But that's really the extent of the unpleasantness the day before. The procedure itself is done under sedation, so there's absolutely no discomfort of any kind. There's no pain. It takes about 30 minutes, and, the only things that the patient remember is saying goodnight and going to sleep, and then waking up in the recovery room saying, is it over yet? And of course it is over, and there's no discomfort. So once we get that propagated to enough folks and it's understood properly, I think the procedure will be destigmatized. It may take a little while.
Why did the age get reduced from 50 to 45?
That is because we have been seeing more and more precancerous polyps as well as malignant tumors developing in a younger population. There is a little bit of difference with race as well. So we were seeing, the age 45 screening was in African American populations earlier than in the Caucasian population, but still, we're seeing that trend. Whether that trend is because we're screening more folks and finding it better than we did before, or whether that trend is because of the dietary preferences of our society, our Western society, or genetic trends, it's hard to tell, but we are seeing that trend. Therefore, the American Cancer Society had recently changed the recommendation to 45 years for the first screening colonoscopy from 50 years. We're still lagging a little bit behind with the insurance coverage. Not all the insurance companies are on board with that, but I think it's moving in that direction.
And it's one of those things where family history is very important, right?
Family history is number one importance, because this disease is very much related to genetic changes. Its environmental impact is minimal or not as well studied. So when folks ask me, what did I do to make this happen? Why do I have these polyps, or why do I have this cancer? I lead a healthy lifestyle. I eat healthy. I don't smoke. I don't drink. so much of this condition is genetic that you can do everything right and you can still develop precancerous polyps. And if you don't remove them in time, they could still turn into cancerous tumors and cause obviously a more advanced disease. Having said that, there are risk factors that are make the disease more likely to occur. Smoking, for example, has been shown to increase all kinds of cancer risk. Different types of cancers, not necessarily colon cancer, but colon cancer is one of it. And that's probably the one and only largest risk factor is the smoking. Alcohol to a certain degree as well, but that's kind of been less studied, less proven. And other than that, it's all genetic. It's all family history, colon polyps or colon cancer, and whether or not that this particular patient has this particular gene that can cause, that can initiate the growth of that particular polyp.
And inflammatory bowel diseases, right, like Crohn's, that can also...
Absolutely. That's another very... well-studied and proven aspect of increased cancer risk is any kind of, there's two inflammatory bowel diseases, Crohn's disease and ulcerative colitis, and both of those show increased risk in colorectal cancer.
So what's the difference between somebody who may not have any of that, family history, they don't smoke, they don't, they're active, they don't have that, like I said, family history, they don't have bowel disease like Crohn's. What's the difference for those folks getting their screenings and how often they get the screenings compared to someone who has a little bit more of those risk factors?
So if a patient doesn't have any family history of colorectal cancer or colorectal polyps, I think whether they smoke or not does not factor into this. It's mostly family history of colorectal cancer, colorectal polyps. If they're 45 years of age or 50 years of age, depending on who you believe at this particular time, they should have their first screening colonoscopy done at that age. And then after that, if no polyps are found, they can have their next screening colonoscopy done in 10 years. So it's every 10 years if there are no risk factors involved. If a patient has family history of colorectal cancer, especially first-degree relatives, mother, father, sister, brother, children, then they should have their screening colonoscopy done every 5 years. If the patient has polyps found on their first screening colonoscopy, and they're considered precancerous polyps, adenomatous polyps. There are multiple types of polyps, but we'll just simplify that for just adenomatous polyps. Then the gastroenterologist or the surgeon may recommend that they would have their next colonoscopy done sooner than that, maybe in 3 years, maybe in 2 years, or in 1 year, depending on what type of polyp it is and how worried that particular practitioner is about maybe returning of the polyp, or that maybe some smaller polyps were missed because they're hard to see because they're so tiny. And so they want to bring the patient back within a year or 2 or 3 and make sure that nothing else is there still or again.
When you talk about the time frames for someone who doesn't have any risk factors, 10 years to even just to what you were just talking about, where it's maybe 1 or 2 years, for what we're talking about here, that's a pretty good time gap. I mean, it's not like you're being asked to come in every couple of weeks or once a month to have a procedure like this done. So I guess it's just going back to your talk about the stigma of it all. I mean, it's not like this is something you're being asked to do routinely. And so there's, when so much of your health is on the line for something like this, it just makes it that much more important, especially when you consider that, again, it's, if there are no factors, it's once every 10 years.
I agree. I think it's very non-invasive procedure to begin with, and also it is fairly infrequently. So I always go back to the dental comparison. I don't know why, but I guess it's one of my pet peeves. I moved to a different part of the country recently, and I had a new dentist, and they insisted that I have the cleaning every 6 months. I've always done a cleaning once a year, but they insisted it was every 6 months, and I can't tell that with all honesty that the cleaning is painless to me anyway. So here I am going every 6 months for a painful procedure, that lasts about half an hour as compared to a procedure. And I guess I should also say that if I didn't clean my teeth every 6 months, I wouldn't develop cancer, and I wouldn't potentially have to deal with saving my life. Whereas you have a procedure that's preventing cancer that's done every 10 years or every 5 years, depending on the family history, and it's painless, and the benefit is so much greater than any kind of discomfort or inconvenience that can be caused by it. So to me, honestly, that's I guess for no better word is a no-brainer. The benefit you get from it is great.
In the dentist chair, you can't fall asleep. It's too painful. As much as you try to fall asleep, you just can't. Here, you can, you put out, and you wake up and everything's done. So, you talked about tobacco being a big factor. What about obesity, staying active, being on a good diet? All things you can control can help.
There are multiple factors that have been looked at and studied, some peripherally, I guess. Obesity, diet such as staying away from red meats and eating more fiber-oriented diet. Use of vitamins, vitamin A, vitamin E, vitamin B, vitamin D. All that has been looked at. Even aspirin, we looked at taking a baby aspirin every day. Does that decrease the chance of developing cancer? Along with some other medications, such as, arthritis type medications. There are questions about all that. I think the evidence may be there, but the evidence is somewhat weak. So, as physicians, we used to make recommendations based on as strong of evidence as we can possibly find, and the studies have been reproduced that have been reproduced and that have been appropriately vetted. So yes, a healthy lifestyle is always a good thing. But having said that, from my personal experience, I can tell you that there's plenty of folks out there who lead a very, very healthy lifestyle, and for some reason choose not to have the screening done. And unfortunately, I've seen way too many of those folks that come to me in their 60s or sometimes even 70s for their first colonoscopy, because now they have symptoms and they end up with terrible colorectal cancer disease. And so I think that a healthy lifestyle is important, but it shouldn't put you in a false sense of security that just because you lead a healthy lifestyle that you are immune from developing this disease or any other types of disease, coronary artery disease, et cetera, et cetera.
What is it about tobacco that causes issues? What is it about, certain foods like meats that causes those issues?
See, that's part of the problem is we don't know exactly the molecular mechanism of why people have increased risk of developing cancer if they smoke, for example, or if they eat more red meat and less fiber in their diet. And that's why we can't be 100% certain that that's a direct relationship, So we see the trend. We see that, smokers, there's more smokers that do develop this condition than people who don't smoke. But without understanding a true molecular relationship, it's difficult to make that jump that say, this is a direct cause. So I really can't answer that question. I don't know. And if there are some direct molecular mechanisms, I'm not aware of any.
You talked about symptoms and being a sign of that things are too late. Once people could be too late if people start experiencing symptoms. What are some of the symptoms that people would experience?
Well, it depends on how far the disease is advanced. So when the polyp turns into a cancerous lesion, the cancer is defined by its ability or its ability is to grow, and it grows uncontrollably, so it never stops growing. So, in other words, a cancerous tumor will never get smaller; it will only get bigger. And as it grows, more and more cells slough off, and more ulceration develops. So the tissue becomes unstable and sloughs off and ulcerates and causes bleeding. So if any bleeding or black, dark stools are seen, which is a sign of old blood that's coagulated, or blood clots, etc., in the stool, that's a very concerning sign for possibly developing colorectal cancer. Obviously, changes in bowel habits, as the mass grows, it obstructs more and more the lumen of the colon. So more of symptoms of constipation, difficulty passing stool, bloating, indigestion, nausea, things of that nature. And then obviously, if the tumor causes perforation of the bowel, then it's an acute issue. Then, it causes peritonitis, and that leads the patient to go to the hospital, the emergency department, because it becomes an emergency.
And that's why, discovering this late it's so tough to treat.
It's absolutely tough to treat, because not only is it very symptomatic and it becomes urgent in a lot of cases, but also the cancer cells don't stay in one place, so they will travel. Every part of our body is supplied by oxygen, and in order for the body parts to receive oxygen, that's what blood supply is for. So we have blood vessels that carry oxygen to the organs, including the colon, but also we have to withdraw the used up oxygen in the form of CO2 and other used up nutrients, etc. And so that some of it is done by the blood vessels, and some of it is done by the lymphatic system. And so the first cancer cells that travel away from the tumor end up in the local lymph nodes. And so, if once they overwhelm the lymph nodes, then they travel further, and they travel to different organs, first of it usually being the liver, because that's where the drainage from the GI tract first goes to. And so then you're talking about cancer deposits setting up shop in the liver, and then maybe in the lungs, and maybe in other areas, and maybe even inside the peritoneal cavity, throughout the soft tissues of the abdominal cavity. So then we're talking about, stage 4 cancer with distal metastatic disease, and so that becomes very difficult to treat or cure at a certain point. Yeah.
So we want to avoid all that. Get your screening. It's very simple.
After I left the military, I missed that feeling of belonging to something and feeling a part of something special. And that's exactly what I got when I came here at Gifford Medical Center.
Apply today. Go to giffordhealthcare.org/careers. Talk us through a typical procedure, what you're looking for.
Well, the procedure is pretty straightforward. So after the appropriate bowel preparation the night before, so taking the laxative, cleaning out the colon, the patient comes into the hospital in the morning of the procedure. We'll get the patient, put the IV in, get the patient all comfy, and bring him into to the endoscopy suite and sedate the patient, basically. So it's like having a nap for the patient. The procedure takes about half an hour usually. We use a flexible endoscope, which is approximately 2 centimeters or 1.5 centimeters thick tube, I guess you could say that. And it's flexible. It's about 6 feet long, and so we can advance it all the way to the very high part of the colon, where the colon is actually joining with the small intestine. And that way we can examine the entire colon from the top all the way to the bottom where the rectum is. And then so we will inflate the colon with gas. At this facility and many other facilities nowadays, we use CO2, carbon dioxide, because it absorbs much faster than regular air and causes a lot less or pretty much none of the cramping and gassiness after the procedure. And so we inflate the colon with air so we can see and we can actually directly visualize the wall of the colon throughout the entire colon. Frequently, we will also go through the what's called an ileocecal valve and actually get into the small intestine as well and visualize the distal part of the small intestine also, just to make sure there's no polyps there, no abnormalities. And definitely visualize the entire colon. If we see any kind of growths or polyps, we remove them right there and then. We have small tools to do that, little forceps and little snares, etc. We use cautery frequently to cauterize the area of the polyp that we remove so there's no bleeding afterwards. And if we see something that's larger, a larger tumor, a larger mass, we take biopsies for appropriate diagnosis. We will mark the area, we'll inject some dye so that in case we do have to go to surgery, we know exactly where that tumor is located so we can remove it with the least possible amount of surgery necessary. And that's pretty much it. Then we wake up the patient up and give them something to eat and something to drink, and they're on their way home within about half an hour, 45 minutes after the procedure is complete.
And it's safe.
It's very safe. There are risks. Any procedure carries risks. I always tell my patients there are two risks that I talk to them about. One is bleeding. If we're taking polyps or taking biopsies, those little areas can bleed a little bit. That's why we cauterize. But usually it's self-contained bleeding and stops on its own pretty quickly. Every once in a while there is delayed bleeding from an area where we take a polyp out. Very rarely is it clinically significant. In other words, we very rarely have to give a patient a blood transfusion or have them admitted to the hospital or anything like that. And then even a more rare complication, but obviously a more serious complication, is a perforation of the bowel. So anytime we put any type of instrument inside of the intestine or any part of the intestine, colon being part of it, there is always a risk that bowel can get perforated or ruptured by that instrument. This is extremely rare occurrences. I think in my career of 20 years, I've done many thousand of these procedures, and I have had 2 bowel perforations from them. So yes, it does happen. It is extremely rare, and we really careful to avoid those.
So if you see something that's alarming to you, a polyp, or you will remove it during this procedure. What if there's something there that is a red flag? Something that what's the procedure then, and how quickly is the turnaround time for somebody to find out exactly what's going on?
Once we remove the polyp, we'll send it off to a pathology department and have our very, very good pathologists section it in small pieces and put it under a microscope and examine it, and then they will tell us what type of polyp it is, how much of a malignant potential it has, if any. And that's within about a week we get that result, and I usually see my patient in follow-up 7 to 10 days after the procedure and give them the results and then tell them when their next colonoscopy should be.
So there are people out there that are still, maybe they hear this conversation, but they're still a little skittish, undecided, and they say, well, I don't need to do that. I can just take an at-home test and go from there. And so there's a lot of debate about at-home tests. I know we've talked about it before. Your thoughts on at-home tests and if they're really reliable?
Well, there are several at-home tests. We used to, for a long time, rely on just detecting blood in the stool. And it's a good test to try to detect microscopic blood in the stool. Unfortunately, it does not detect any precancerous polyps. It detects either cancer that's already so large that it's already bleeding, or it pretty much just can catch bleeding hemorrhoids, which have nothing to do with cancer. So it's a test that doesn't have very good sensitivity or specificity for colorectal cancer specifically. In the past few years, we've had a couple of different additional tests, the FIT test, the FIT, it's an immunoglobulin test, or we have a Cologuard, which I'm sure a lot of folks have seen on commercials on TV. very cute commercial. And Cologuard is a good test. It does detect certain DNA patterns from the colorectal cancer. So it's more than just a blood test. However, even though it's fairly good in detecting developed colorectal cancer, it has 92% effectiveness in catching colorectal cancer, which means it has 8% chance of missing colorectal cancer. So I always, as a physician who does this for a living, I always look at that side of it, not the 92% side of it. But in any case, it does have 92% chance of detecting cancer. Unfortunately, the literature that was used to approve this medication also states that it detects between 42 and 50% of polyps that are greater than 1 centimeter, which means about a half an inch. So most of the precancerous polyps we remove are in a range of 2 to 5 millimeters, so half a centimeter. So the Cologuard detects 42 to 50% of polyps that are greater than 1 centimeter. So it misses over 50% of polyps that are greater than 1 centimeter. So it misses a lot more, if not, I would say, the vast majority of the polyps that are less than 1 centimeter, which are most of the polyps that we remove that are precancerous. So in my mind, Cologuard is useful, but I don't think it's as useful for prevention of the cancer as it is for detection of the cancer. So, and I think that is the main thought difference that I have with some of the patients that I see and some of the providers that I talk to, is that I don't think there's that full comprehension of detection versus prevention. It's good to be able to detect the cancer early, but it's better, in my mind, to prevent the cancer from happening in the first place. And I don't think that Cologuard does that. And I think the Cologuard folks understand that, and that's why they publish this research openly, and you can see it, in their own literature. So we have to be careful. I think Cologuard has excellent potential for folks who either absolutely will not do a colonoscopy, they refuse to do it, they don't want to do it, they're not going to do it. Then absolutely it's better than nothing. It is definitely better to have that done. Or for the folks who cannot have a colonoscopy, they're medically not cleared for a colonoscopy. They're so ill with other things that they cannot withstand the procedure. Absolutely, for that purpose, they should have a Cologuard test. But for a person who is healthy and who can undergo colonoscopy safely, a colonoscopy is still the gold standard by a long stretch.
You talked about having, over your 20 years, seeing patients and having the colonoscopy done when it is too late. Tell us this, do you have any stories of the reverse? Somebody coming in and you catching something that could have turned out to be pretty bad? Oh,
I have very many stories of that. As I said, a few years in practice, I've done many colonoscopies on folks who are 50 or who are in their late 40s. That's their first screening colonoscopy with absolutely no symptoms. And we detect colorectal cancer. The majority of those folks, it's a very early stage. So stage 1, so once we do the operation and remove that part of the colon with the cancer and determine that there is no spread further than the colon, then a lot of those folks don't even need chemotherapy or any other type of adjuvant treatment afterwards. And it runs a gamut. I've seen, had patients have taken care of patients who I do their colonoscopy and they're in their mid-50s or early 60s and find the cancer, and it is a stage 2 or stage 3 and it doesn't need to have chemotherapy done. But most of those folks are cured afterwards. As long as it's not a very advanced stage 4 disease, most of those folks can be cured, and therefore the earlier the colonoscopy is done, and I would go as far as to say one colonoscopy at 50 and no more colonoscopies afterward, given that nothing is found at 50, is better than no colonoscopy at all. So even if you're not going to do a colonoscopy every 10 years afterwards, still go and get your first colonoscopy done for first initial screening to make sure that there's nothing precancerous in there, at least for your peace of mind, for your doctor's peace of mind. And then you make that further decision later in life. But it's very important to have that first one done.
And now that the recommended age is now 45, just if you get it done on your, right around that time, you put it and nothing's found, you've now you don't have to worry about it for a long time before you have to think about it again, and you just kind of get it out of the way. And it's, again, when you think about this particular type of cancer and how it's something that when you start to get the symptoms, it might be too late. I mean, this is just one of those few things that screening is really the only way to treat it and get rid of it early.
Absolutely. Yeah, you definitely do not want to wait for symptoms on colorectal cancer. Colorectal cancer or pretty much any type of internal cancer is not like, I have shortness of breath, I got to go check my heart. I've got, my something hurts, I've got to go check it out and see if there's something wrong with it. Colorectal cancer will not give you that warning. Just like any other, breast cancer will not give you that warning unless you actively look for it. Esophageal cancer, pancreatic cancer, none of this will give you that warning. Fortunately, with breast cancer and colorectal cancer, we have ways of detecting it early. Some of the others, like pancreatic and esophageal, or lung cancer even, there's no way we don't have a developed system of prevention and screening for those cancers. So for colorectal cancer, we have one. So let's use it. Let's be proactive with it.
Well, Dr. Sokolovsky, you've given us really great information here. And hopefully, if this has just encouraged one person to convince them to go get their colonoscopy, I think, we've done our job here today. And so it's really very fascinating. I mean, it certainly was fascinating to sit in on a colonoscopy and see the procedure done. And, for people that might have those fears or, hopefully we can put a little bit of those to rest.
Sounds great. It's my pleasure taking part in this. I appreciate the opportunity. And I hope that the community understands that we're there for them. We're here to make sure that they're healthy and that nothing bad happens to them. And that's really the only reason we're here.
For more information on the general surgery department here at Gifford, you can call 802-728-2430. Again, 728-2430. We were talking about colonoscopies, colorectal cancer screenings, but the Gifford General Surgery team of Dr. Sokolovsky and Dr. Holman do a wide variety of procedures, and you can check out all of those procedures on our website, giffordhealthcare.org. Click on services, look for general surgery, and you'll see their lovely photos on the website, and then it'll give you a little bit more background information on what they do. And that's going to do it here for the Gifford Provider Podcast. Again, thank you for joining us, whether it's on YouTube, on Apple Podcasts, Google Podcasts, Spotify. We do appreciate it. And leave a comment or share with your friends. Subscribe, download. We really do appreciate it. And until next time, this is Scott Fleischman for Gifford Healthcare. We'll see you next time on the Gifford Provider Podcast.